Thank you everyone for joining our webinar. My name is Shadi Reyes. I'm going to be the host for this activity. I'm currently the Director of Interventional Cardiology Research at Detroit Medical Center. DMC Medical Group going to be coming to you in a series of lecture from Detroit Medical Center to talk about topic and the title of the series called Heart to Heart Discussions. We'll start with that with a video coming to you from DMC. The faculty for tonight is Dr. Kenton Zer. He is the Executive Director of DMC Cardiovascular Service Line. He's also Clinical Professor of Medicine and Surgery at Wayne State University School of Medicine. Dr. Zer has been with us for 2 years now, and he has been building tremendous team in the cardiovascular care in Detroit area. Dr. Zer today will talk to us about the management of multivessel coronary artery disease, PCI versus surgical options, a very important topic that primary care cardiologists in the community are dealing with on daily basis. But we're gonna take his perspective as a surgeon and with his tremendous experience for more than 25 years in heart surgery. Dr. Zer, please go ahead and share your screen.
You can see me, Chadi?
Absolutely, we can see you and hear you.
Welcome very much to our 1-hour program here. I'm going to talk about multivessel and left main coronary artery disease, looking at PCI versus coronary artery bypass grafting. And remember, this is the story as told by a surgeon. But I'm going to try to look at the historical evidence and try to paint a picture for what I think the strategy should be for multivessel disease and left main coronary artery disease. My slides are not advancing. There we go. The struggle itself toward the heights is enough to fill a man's heart. That's what Albert Camus thought, and we should be happy with his struggle. And the struggle as it pertains to the life today is that cardiovascular disease remains the #1 world cause of death currently. Just an article about it yesterday in talking about this. And we've been pushing this stone upward for the last 50 years in cardiac surgery to try to improve outcomes. And cardiology has done that as well in the PCI arena. We have to be careful that our own biases don't obstruct our road forward. And that's true in cardiology, and that's true in cardiac surgery. And I'm going to come at it from a surgical bias, but I'm going to try to present that bias from a scientific point of view. In the 90s, as published in Circulation, there was a dramatic increase in the number of PCI procedures from 285,000 to over 1 million. So almost a 4-fold increase in the number of procedures. And you see on the right-hand side, this became 66% of all procedures done total of PCI and coronary artery bypass grafting in the United States. So we had a dramatic increase in PCI and proportionally a significant drop off in cardiac surgery over that period of time when we had the development of stenting procedures. I'm going to go back and look at 3 of the studies that were done as the initial randomized prospective trials between medical therapy and coronary artery bypass grafting. And the first one is the European Study Group, published in the New England Journal, which showed that coronary artery bypass grafting improved survival in patients on the right with left main coronary artery disease and with proximal LAD stenosis. And as you see on the left, there was very little improvement in patients that did not have severe disease, such as proximal LAD stenosis. It was absent. Now, the VA cooperative trial is another one of these 3 that was published very early on looking at medical therapy versus bypass grafting. And they concluded that if you're a low angiographic risk, in other words, patients did not have that significant of coronary bypass grafting, medical therapy did almost as well. However, if the patient had 3-vessel disease or impaired left ventricular function, there was a survival benefit out to 11 years. The third study is the CAST trial. That was published in Circulation in 1990. That also showed that patients that were sicker, i.e. an EF of less than 50%, were better served with an initial strategy of coronary bypass grafting with an improved 10-year survival and freedom of death and anterior wall myocardial and acute myocardial infarction. Now, there was a study done by a meta-analysis done by Yusuf in the Lancet of 7 randomized trials, including these 3 other trials, with results out to 10 years. And what you see here is the extra month of survival that was added by giving with a strategy to go to coronary artery bypass grafting instead of medical management. And we see there was a dramatic improvement in patients with left main disease, with 3-vessel disease. And as you get down into the low and moderate risk patients, not so much improvement. These were the first studies that showed us that advanced disease was served well with coronary artery bypass grafting. And the conclusion was there was definitely an increased survival with left main disease, with 3-vessel disease, particularly in the setting of left ventricular dysfunction and or severe ischemia, and even 2-vessel disease if they had proximal LAD disease. Now remember, all these trials were done prior to the use of arterial grafts, i.e. the internal thoracic artery, the left anterior descending coronary artery. Therefore, we see the curves start to come back together in 10, 11 years when we see saphenous vein grafts start to go down. So we have definitely improved our way of doing things, and we have to be careful that as cardiology moves the chains with improvement in stent procedures, we have also moved the chains with an improvement in our technical abilities and the type of operation that we offer. Now, if you want to look at the same time period, looking at medical therapy versus PCI in the same kind of head-to-head relationship, we see that there was a much more difficult time proving that early PCI, this is in the absence of stents, mind you, but with angioplasty, medical management on the right in most studies was just as good or better than PCI. This is early PCI. So it was much easier time during this time frame to prove that bypass grafting did better than medical management than PCI against medical management head to head. Then we enter an era where angioplasty became very popular, and this is in the 90s. And you see the acronyms on the left-hand side in the regions where these studies originated from, and there were multiple randomized prospective trials looking at PCI versus CABG. Now, very few of these studies included many stent procedures, so it's really, in some ways, not a fair comparison to the modern era. But it is valuable to look at it for a few conclusions that can be drawn from these studies. Now, of these studies, only 2 to 12% of screened patients were randomized. And they excluded the very patients that benefit the most from bypass grafting: recent MI, prior revascularization, depressed ejection fraction, and excluded left main disease. And the lesions must be amenable to both PTCA and to coronary bypass grafting in these studies. But of the 13 randomized trials, there was an absolute survival advantage, which favored bypass, which was statistically significant at 5 years. And in all of these studies, there was a significant survival advantage out to 5 to 8 years. And in diabetics, it was better than in the other patients. And these studies were the first to start to show that perhaps there was a signal identifying diabetics with severe disease as even doing better with bypass grafting than with PTCA.
Dr. Zara, I have a question, also a
Sure.
comment. If you go 2 slides back, says the recruitment was only 2 to 12% in the trials, which tells you how much challenging and somehow it's hard to kind of generalize on other patients we see on daily basis. These
Well,
are kind of the
I'm
handpicked
going to
population.
progress. I'm going to include a few slides about registries.
Yes.
And the registries include all the patients which were not randomized for these studies during
Daily
this
practice.
period.
Yes, exactly.
I have a few slides on the registries, and we'll talk about that later. We see here in these studies that pretty much all the studies favored bypass grafting, and it got better when we went from 1 to 3 years to 5 years to 8 years. Now, that being said, these two studies show there was less favorability when stenting was introduced within these PTCA studies. Therefore, there's no question that stenting moved the improvement in bypass back toward not as much survival advantage than
yes.
prior to when it was just angioplasty alone. I think that this is an important part of the historical story. It shows stepwise progression and improvement in the cardiology treatment of patients with coronary disease.
Yes.
Now, this is just showing that I mentioned before, in these same trials, we start to see a signal that diabetics do better with surgery as opposed to PTCA. The hazard ratios are higher in the diabetics than they were in the general population in these studies. And you see there's a large number of diabetic patients enrolled in these randomized trials. Now, this is just another slide looking at several of these studies, looking at the improvement with diabetics with surgery versus PTCA. And all diabetics, not so much, but the insulin-dependent diabetics more so. And all the studies showed it, including the Berry trials, both the registry and the randomized trial. So concluding these historical studies, the first ones that were done with PCI versus bypass, there was no real long-term significant difference in survival, but in the diabetics, there was a significant difference in survival. And when we started to get into PROX-LAD lesions and 3-vessel disease, CABG was definitely improved, but PTCA was better in 1-vessel disease, not involving the proximal LAD. And we know that there was more complete revascularization in the bypass group and better anginal relief. Now, there was an interesting paper that was written in Circulation. So we had the results of the Berry trial, which originated out of the Mayo Clinic and started to show that diabetics had a signal that were better. And there was, in this study in Circulation, they looked at Berry-eligible diabetic patients that underwent PCA prior to the Berry publication and after. And they found out that 28.6% underwent PCI before and 26.8% after. So practice was not changed despite the Berry trial looking at diabetics and 3-vessel disease in a head-to-head comparison. And of the survey responses, 91% were aware of this clinical alert, which pointed out this signal. 76% felt the findings were valid, but only a little over 50% felt that the alert had any impact on practice patterns. And if you look at it on a bar graph, I want to concentrate on the one 5 to the right, 5 to the left. Medical advances made the Berry results obsolete. So already we're seeing a rock in the road, like I showed in the third slide, that's obstructing the pathway a little bit toward what maybe is best for the patients in diabetics with severe 3-vessel disease. We see here 80% of the cardiologists felt like advances had made the results obsolete already at the time of publication of this trial. So we sometimes are our own stumbling blocks into doing what's best for our patients because of our own personal biases. If you now look at some registry data, these are patients that are part of just the New York State Cooperative Registry data. And it's patients treated 20 years ago, but it's a large group of patients. It's worth looking at the study. There were 37 bypass patients, 22 PTCA patients that were stented. And the endpoints were death and subsequent revascularization. Huge group of patients. We see here there was a better survival achieved with bypass in all anatomic subgroups. after adjusting for severity of illness. It was 4.9%. Subsequent revascularization required in the CABG group compared to 35%, which was dramatically significant in this series. And these were all stented patients in a registry. And if you then plot severity of disease and then plot which is better, PTCA or CABG, and these are stented patients, you start to see as the disease gets more progressive and you start including proximal LAD disease, you get to a point where it's pretty clear and the error bars don't overlap the midline, that coronary artery bypass grafting offers a survival advantage at 3 years.
And Dr. Zara, this is a very powerful slide to show, because this is replicated almost the same findings in the syntax you're going to show us later. So this is even 20 years ago, the findings still exist 20 years later.
Chadi, part of the reason I present this as a historical perspective is it holds together over 50 years.
Still holding the same.
Most of the data is the same. You can find the occasional study here and there which varies a little bit, but most of the data is the same. We're looking here at this slide. This is this New England Journal article still with the New York State registries looking at CABG versus stent in 3-vessel disease if you have prox LAD lesions. And here we see the same 5% difference mapped out at 3 years. This is from the Duke database. And you remember 2 slides ago, I showed you a very similar slide. PTCA is clearly better. Single vessel disease, when you have less prominent disease, because you're taking the morbidity of surgery out of the equation in these categories. PTCA is definitely better. But as you get into patients that have 95% proximal LAD lesion, you have proximal LAD lesions, you have 3-vessel disease here in these categories, you start here, you see the hazard ratios shift toward bypass being better. Now, a couple slides on the effective strategy. Which should be first? Should you stent patients first or should you bypass them first? And there's some papers that have been published in this area. We know for a fact that if you completely revascularize a patient, they do better than if you don't completely revascularize a patient. There are many papers in the literature. This is just one, showing all-cause death and cardiac death is worse with incomplete revascularization across the board. And these curves tend to diverge as time goes on. So it's best to bring better blood flow to all areas if you can with the primary strategy approach. Now, we also know that if you have been stented and then you have in-stent stenosis, you don't fare as well, certainly as if you don't have any stenosis. But if you have in-stent stenosis, your survivability goes down. But really importantly, if you have an occlusive restenosis of a stent, then you have a real drop off. And you see here out to 10 years, there's only a 40% survival in those patients. So durability of what you're doing to somebody is very, very important. And I'm just putting this slide up to say that when we put bypasses on all the territories and we know our durability of the grafts, we eliminate this line as part of our follow-up with coronary artery bypass grafting. Now we have graphs that go down and we know our rates. I don't have slides as part of this presentation. Maybe I should. Now, here's an initial strategy looking at the New York Registry. If there was an initial strategy here you see the disease at the bottom, the degree of the coronary disease they had. If the initial strategy was bypass in patients with lesser disease versus more disease, we see that in general, with the if initial stenting was part of this plan to treat this kind of disease, the mortality differences were about, you can see the relative excess percent mortality associated with all those 5 categories I showed earlier. And as the disease progresses, there's a 46% higher mortality in the initial strategy to stent as opposed to do bypass. This is just part of the argument that as the disease gets more progressive, perhaps the initial strategy should be bypass the patient, stent the patient second. Cleveland Clinic looked at just a general mortality at 5 years, looking at a hazard ratio of PCI versus coronary bypass grafting, and with propensity analysis of a huge number of patients, 6,000 patients, with which Eugene Blackstone is known to have really popularized this way of treating data, they found that there was a 2.3 increased hazard ratio for people with a PCI initial strategy compared to bypass for coronary artery disease. Now, what is the newer evidence? Because there's definitely been progress in terms of stents with drug-eluting stents. Have they changed outcomes, say, compared to bare metal?
A lot of physicians, I think, on the call will be questioning that as well. Newer development, new iteration of stents, is the outcome changed?
Well, we saw that, Chadi, we saw that earlier with that Berry survey, which the majority of the cardiologists, 80%, said the Berry results were obsolete because now we have new therapies. Well, this is just a meta-analysis looking at drug-eluting stents versus bare metal stents. And as you see, the odds ratios are pretty much down the middle for the Ravel study, the Sirius studies, the Taxus studies. It's pretty much a wash for mortality that bare metal stents and drug-eluting stents were not that different. And if we look at a forest plot of myocardial infarction after bare metal stents versus drug-eluting stents, we see a very similar forest plot. Not a huge difference in most of the studies with drug-eluting stents versus bare metal stents. Is this fair slides, Chadi?
Absolutely, yeah. Yeah.
Now I'm gonna present just a few more slides and then we'll get to discussion, looking at a couple trials which are more modern. And this is a Syntax trial. This was 62 European sites, 23 US sites. And it was randomized prospective trial between drug-eluting stents, which was Taxus stents, and bypass grafting. And we now have 10-year follow-up. We first saw the 5-year follow-up data, and now we have the 10-year follow-up. So a modern stent and modern coronary artery bypass grafting procedures where everybody got a lima to a left internal mammary artery or internal thoracic artery to their LAD. And we see all-cause mortality for the entire group is roughly the same. It's not significant difference between PCI or coronary artery bypass grafting. Remember, this is all comers with all kinds of disease. But if we look at the 3-vessel disease, now we see significance. And this is part of the same package of the historical literature, which tends to show us in this direction using modern techniques. There's a fairly significant difference in mortality out to 10 years, and with good follow-up in this study. Left main disease is one that is not so clear. And I think that, and I have a few left main slides later that I'll show you as well. It does seem that there seems to be equipoise with left main in these left main disease in these randomized trials. And if you look at all-cause mortality in relation to what the Syntax score is, in other words, the Syntax score basically is, do you have a low burden of coronary disease, medium burden of coronary disease, or a high burden of coronary disease? We see when we get Syntax scores greater than 33, high burden of disease, across the board, patients did better, and with 3-vessel disease, and with left main disease. But you see here that when the Syntax scores were less than 32, those patients did better out to 10 years with PCI versus stenting. And in the other categories, 3-vessel disease with a low burden of coronary disease and all comers, the 3-vessel disease with a low burden of disease did not, it's hard to argue there's a benefit when the dot is right on the line and the error bars on both sides. Now, back to diabetics. I think it's still pretty clear with a modern study, randomized trial, looking at a drug-eluting stent with PCI versus coronaries in the Freedom trial, that across the board, patients did better in these diabetics. So diabetes throws a wrinkle in the curve, even with low burden coronary disease if it's 3 vessel. And patients did better with death, stroke, and MI alone, all-cause mortality, repeat revascularization. But if they were frail and disabled, they did worse with surgery. They couldn't handle the morbidity of the surgical operation. So this is something that we need to keep in mind when we say, oh, diabetics with 3 vessel disease should go to surgery. Maybe they shouldn't if they're wheelchair bound, if they're frail, if they're elderly. And it's an important caveat to the Freedom trial. Now, what a few slides about left main disease. There have been some good studies over the last decade or so that have been published. This one's from Korea in the New England Journal, head-to-head matchup, 300 patients in each group of left main stenting versus bypass grafting. And here we see, if you look at major cardiac or cerebral vascular events, there's a signal toward patients doing better, but it's not statistically significant. But if you then look at mortality, it's spot on. So this manuscript was presented to show equipoise in the left main group, similar to like I showed with the Syntax trial earlier with left main disease. The Delta registry out of Europe is also one that showed exactly the same thing. There was a difference in MACE rates, but there was not a difference in death or MI in left main disease in the registry data, as well as the randomized trial I showed earlier. Now, the most recent trial is the XL trial. It's been a bit controversial, as we all know, because David Taggart pulled out of the study as an author because he didn't like the way the data was analyzed. But it's a very large group of patients. It's 2,900 patients randomized with a Syntax score of less than 32, so low and moderate burden of coronary disease, randomized to drug-eluting stent versus coronary artery bypass grafting. And it's not significant difference. In fact, in the first 2 years, the death, stroke, or MI rates were higher in MRI, or higher in the CABG group, largely probably because of perioperative morbidity related to surgery. And then we see that these curves diverge some, with PCI being a little bit worse, but it's not statistically significant. We'll see what these results look like as they follow this study up further. If you look at a meta-analysis of all the studies that were done recently, we still see with left main, the most studies CABG is favored, but we can see with this kind of a balanced look at the literature that there's more equipoise than with say 3 vessel disease patients with diabetes. Now, that being said, the last guidelines that have been published still reflect the older literature that I presented earlier, where anything with proximal LAD and a higher burden of disease has very good data suggesting that it's totally appropriate to treat these patients and steer them toward bypass. If you have lesser disease, it's appropriate to steer them toward PCI. With left main disease, still the guidelines say it's not appropriate to primarily treat with a strategy of PCI, particularly if they have a high burden of disease like this. If they have a lower burden of disease, unclear. Now, this is a slide I borrowed, and this is a surgical bias, and this is borrowed from Craig Smith, who's the chair of surgery at Columbia, and who operated on President Clinton. Blood must pass through in PCI. This is why PCI tends to have an Achilles heel. It passes through a critical choke point. That choke point is prone to native disease. That choke point is rarely focal. The choke point contains a foreign body now because you're putting a stent in there. That foreign body has a drug and a matrix, and that drug might inhibit more than just neo-intimal hyperplasia, where coronary bypass grafting tends to succeed because we use a relatively normal conduit, particularly if we use an artery from the chest wall. We make one anastomosis, and as a surgeon, you get to pick the most normal segment of the coronary target beyond the blockage. And this is why I think we're still gonna remain relevant in patients with severe disease. So, and again, in my conclusion side, definitely has a surgical bias, that there's never been a long-term study showing PCI to be superior to coronary bypass ever. In both the old and the new data, it tends to favor bypass grafting. Clearly, the more critical disease, the better bypass does in patients with left main and multi-vessel disease, although I'm willing to concede that the literature now is suggesting there may be equipoise in patients with left main disease and a low burden of coronary disease. And I think it's pretty clear now that diabetes with multi-vessel disease have a significant survival benefit from bypass compared to PCI. Thanks very much for your attention. I'm happy to take any questions. I know Chadi is as well. He knows the literature very well.
Thank you, Dr. Zer. So I have one question from the audience, but I'm going to start just to simplify it to the audience and people on the call. Let's say, what would be the first step? You do an angiogram and you see three-vessel disease on angiogram, or somebody come refer to you as a cardiologist or primary care, they tell you this patient has three-vessel disease. What they should be doing and evaluate the risk and benefit of PCI versus CABG?
Well, I think from a surgical perspective, we have a very powerful tool, and that is the STS risk assessment. And that is available online. And you don't have to have a special password. You just have to identify yourself as a physician. And I'm not even sure you have to. I think a patient can do it as well.
Correct.
And basically, you enter it. The STS database, for those who are unfamiliar, is a national database which has been bootstrapped backwards many times to look at the validity of the data. And it includes millions and millions of patients that have undergone cardiac procedures. And there are 7 categories which can be assessed fairly well. The number 1 is the coronary bypass grafting, both in reoperative situation and first-time situation. And basically you plug the data in and it spits out the number for what the risk of mortality is with the procedure and what the risk of all the morbidities are, including stroke, perioperative myocardial infarction, takebacks for bleeding, prolonged ventilation, and things like that. And that number, you can hang your hat on that that's probably that patient's risk. So normally you take a person like myself, my risk undergoing coronary artery bypass grafting is going to spit out a number somewhere between 0.5% and 1% of mortality. And so if that number is 5 to 10%, then you start thinking the risk benefit may well be on the side of PCI, because already in the perioperative mortality risk, you've eaten up the risk benefit for 5 years, which is only about a 5% difference. So if you're accepting a 5% risk of mortality with coronary bypass grafting, looking at these studies, your risk at 5 years isn't that much better with bypass than PCI. So you should start thinking risk benefit is multi-vessel PCI.
So what is, as a surgeon, will be your kind of cutoff?
I worry at 5%.
You worry at 5%. Okay.
I worry at 5% because 5% we've played with the numbers a lot in the risk calculator, and you can see what you put in when you put things in there, what tends to increase the risk dramatically, like dialysis dependency, like past history of stroke, like severe peripheral vascular disease. These are the things that are red flags for us. And like I say, if you're taking a patient to the operating room with a 10% risk of mortality, and you're only giving them at 10 years an extra 10% survivability with bypass versus PCI, it's pretty foolhardy to take that patient to the operating room.
Absolutely. So this is a powerful tool, as you said, available online, and majority. And this is one of the things as a primary care or a cardiologist should do themselves before present the risk to the patient and their families, because this is
Chadi,
usually what the first line of talking to the patients about these things.
Chadi, it's actually a metric within the Michigan Cooperative of the Cardiac Surgical Programs that we have discussed the STS risk score with the patient prior to taking them to surgery. And I know it's also becoming part of your practice as well, because I know that every patient you ever send to surgery, you pretty much know what their STS risk score is.
Yeah. Other question coming from the audience is, what is your approach to patient with isolated left main disease? As a surgeon, what factor you consider before deciding CABG versus letting this patient get a PCI?
Well, that's a great question. Sometimes we don't even see the patient because the cardiologist has already decided that they're going to do a PCI on the patient. And those patients, I'm not aware of that denominator.
Mm-hmm.
You know, I know only the numerator. I only know the patients that I'm consulted on. We do the best with left main disease. Like I tell the patient, if the blockage is in the trunk of the tree and we bypass the branches, we get all the branches.
Yes.
And so we like tight left main disease with no other focal lesions, because we know we're going to get a long-term operation. And if we put double internal thoracic arteries on that patient, one to the LAD, one to the obtuse marginal, we know that we're probably going to get a lifetime operation if we manage their cholesterol and we manage their risk factors in the postoperative period. So those are the patients we like.
Do you practice? Yeah, go ahead.
That being said, those are precisely the patients that have equipoise with PCI, like the osteo left mains and the mid left mains. Because if you think about it, it's the biggest vessel on the heart.
Yes.
And it's the one the most likely to stay open longer than other things, just like an iliac stent stays open better than a peripheral vascular stent in the legs because it's just bigger. And so, I think that we will probably lose most isolated left main cases, even though that's what we like to see surgically because we get a good result. I think clearly, just to finish, I think clearly patients with multivessel disease and left main disease, those patients should go to surgery.
Absolutely, yeah. Do you practice or recommend, you showed us on the syntax score, if you, on the right side of the graph, if the syntax score is low, there is kind of favorable PCI, but as your syntax scores goes higher, the CABG is favorable. Do you practice that, or do you discuss that with your patient and the referring cardiologist?
Well, I mean, I think I factored it into my conversation. Like I say, if a patient has a low burden of disease, syntax score less than 22, I don't think I'm ever seeing that patient. I think that patient in the current era gets a stage PCI.
Okay.
Now, we can argue that till the cows come home, but it doesn't matter if I don't see the patient, because I'm not going to render the patient an opinion.
Right.
I tend to tell my patients exactly what I just presented in the last half hour. I tell them the data suggests that you're going to get a more durable result with your category, with your burden of disease based on studies, both old studies and new studies. And I think, that the slides that I presented, if you look most at the references on the bottom, you will see mostly Lancet, Circulation, JACC, New England Journal. So those are, as you know, and as most of the audience knows, those journals are very strictly peer reviewed, and manuscripts don't get published that are significantly flawed usually. If they are, they usually get retracted, or some other study gets published in follow-up that refutes that initial study. So I think it's fair to hang your hat on that and present that to the patient as what the current understanding is.
Now, we spoke about multivessel, we spoke about syntax score and severity, but we didn't touch on the LV function. Would that change your approach to three vessel or left main if there is a low pump function, low EF?
Well, we don't like low function. We just don't like LV
Nobody likes
function.
it.
So we want to see the patient before their EF is 0 or 15% or whatever.
Right.
We have some tools in the operating room now, which are life-saving, that we can get sick patients through. Number one is a balloon pump. Everybody's familiar with an intra-aortic balloon pump, which is a small catheter-sized device that slides in the femoral artery, and it inflates and deflates with helium in sync with the heart. So it provides significant afterload reduction. And in coronary disease, it provides increased coronary flow, because when it inflates, there's dramatic increase in coronary flow, what we call augmentation. So that has been life-saving for these low EF patients. I did one this week with an ejection fraction around 15%. We put the balloon in before we did the sternotomy, and we've so far had a very good result in a patient with severe three-vessel disease and 5 bypass grafts put on him. So we can get these patients through. So I think that those patients should be referred for a surgical eval.
We have two more questions that are very interesting. The first one is the hybrid approach. And me and the research team here, we already did the meta-analysis on this topic, but when do you consider hybrid approach? What I mean by that is PCI to the non-LAD disease and Lima to LAD.
That's a tough question for a surgeon to answer, because in the current era, we now have an option to put a second mammary on, to put a second internal thoracic artery on, usually to the second most important vessel, which is the obtuse marginal. If you ask most surgeons anecdotally, they will tell you they've rarely or never had to redo a patient that had double mammaries put on them, because it tends, even if the right goes down, the two mammaries tend to hold the patient over and keep them anginal free and myocardial infarction free. So we have a second option of putting a second mammary on, which you cannot do, which if you're going to add a third, just add a third at the same time. It adds 20 minutes to your cross clamp time. I'm not a big fan of the hybrid approach for the very reason that the MACE rates for PCI are higher than they are with a coronary artery bypass grafting. So I would say if you're going to open the patient's chest up, put a graft on, you should just do them all.
And then if the venous graft goes down,
if you're a relatively rapid surgeon, it just adds 20 minutes for each graft, adds 20 minutes to the time the heart stopped.
Right.
Now, that being said, that hybrid approach works very well in some centers, which are taking down the internal thoracic artery with a robot, and they're sewing on the heart like as a mid-cab through a very small hole, so they don't have the morbidity of the median sternotomy. So I think with focal lesions in the obtuse marginal, focal lesion in the right, those centers are perfectly justified offering their patients a hybrid approach.
Yeah.
I think that my bias is that it's very difficult to sew well when you don't have an arrested heart and a bloodless field and good vision. So therefore, I think the most important part of what we offer is arterial grafts to the anterior wall, and that you need to have a 95% patency at 10 years and even 20 years, as the Cleveland Clinic showed, to be able to say, we're offering a good cardiac surgery. Therefore, I'm not a huge fan. Long-winded answer, but I'm not a huge fan.
All right. Question also related to, which we kind of alluded to earlier, but I expect the answer. Is there any information on data regarding the impact of moderate or severe diffuse coronary calcification on CABG outcome, short and long term, meaning high syntax score? I think that's what it means.
Well, I mean, I think the short answer to that question is the syntax trial. We have
Right.
10-year data, which shows a fairly significant survival advantage of about 10%
Right.
in the coronary bypass graft, and those are those patients.
Correct.
Now, we know there's subgroups of those patients that are diabetic that aren't going to get a good outcome with anything because their lesions are like a string of pearls along the coronary artery. And what are you going to do? Graft 10 grafts to that vessel? You can't. So there are some things that I do in those patients sometimes that's maybe a little different than conventional wisdom would say. Sometimes I put double mammaries on those patients, even though they're diabetic. I take them down in a skeletonized fashion, so I reduce my risk of having a sternal wound infection, and I put an artery to the LAD and an artery to the obtuse marginal, even though they're lousy targets, because I know that's going to stay open no matter what. So it's a lousy target, but it's a great conduit, and it's not going to go down like a vein will surely go down in those patients on the lateral wall particularly. So I think we can improve our outcomes using more arterial grafts on those patients.
All right. Question. You mentioned already the Excel trial, which compared PCI to CABG for lone left main disease, but also where there is a Noble trial. I'm not sure if you are aware of it or came across it.
I'm aware of it. I don't know the data well, though, Chatty.
Right.
You
So
put me on the spot.
yeah. So there's a comment from the audience saying about the Noble trial. So Noble trial was similar to the Excel trial, so European based, but at 5 years, CABG patients were doing better. And there was a big debate. I remember when Excel trial was presented, say, what is this discrepancy between Excel and Noble? And it was very hard to reconcile.
But as you know, Chadi, if you look at, say, even registry data from the Europeans looking at left main stenting, it matters dramatically where that lesion was in the left main.
Yes.
I mean, if you have a distal left main lesion and you got to put kissing balloons in there and you're doing a distal stent in the LAD, those results, particularly in the Le Mans trial, I believe it was, were not nearly as good as mid left main or osteal left main stenting.
Right.
And that just goes to, of course, that just follows logically and anatomically that that's going to be true. So I think that it takes some common sense, looking at that left main lesion as a PCI specialist like yourself. When you look at that left main lesion, if it's going to be tough or if it's going to be an easy one. If it's going to be a tough one, you should send the patient to surgery. If it's going to be an easy one, then you should do it. Because obviously you can argue both sides of the equation of the Noble versus the XL, or some of the other studies like the syntax trial, which showed that with a high burden of disease, they should have surgery with left main disease.
CABG done, yeah. And we have mutual patient together where they have a solo left main disease and they have severe PAD disease, that shoots their STS score, in the 5 range. But still they did well with surgery because the fact that their pump function is low, and you're going to do Impella supported PCI, compliance with the dual antiplatelet therapy becoming a concern. So therefore, surgery was kind of a better option for these patients, and they did well as well.
Chadi, I think it's a fair statement to say, I'm going to go bold here. I think it's a fair statement to say coronary artery disease requires both. It requires both disciplines, if you want to call them disciplines. It requires both PCI and it requires both surgery. Yes. I think at the end of the day, most patients are going to get both of them sometime in their life. And I think the best thing to do is to make the wisest decision at that moment when the patient comes in with an NSTEMI or a STEMI, and based on what their function is, based on what their burden of disease is, based on what their life viability is, based on all this data that we have looking at risk benefit. Like I say, it's pretty obvious if you're taking a patient to the operating room that has a morbidity and mortality, which is through the roof, you're not going to gain any survival advantage at 10 years. So we have to be sensible there as well in not being overly aggressive when we do have incredibly capable interventionalists in our community, in our academic centers, everywhere. Incredibly capable people, and you have tools as well, like the Impella that you mentioned earlier, that gets patients safely through procedures that you never would have attempted 10 years ago.
We have a couple of final comments is about the NSTEMI versus stable ischemic disease, meaning somebody come to the office, angina, stress test positive, no troponin, and we found 3-vessel disease, compared to somebody come through ER with chest pain, troponin leak thousands or hundreds, and then 3-vessel disease. Would that change your approach, or would that change your thinking of this is going to have a good versus bad outcome?
Well, for us, it doesn't change the outcome. Although there's good data to suggest that the longer you wait after an MI, the better a patient's going to do with surgery, out to 2 weeks. I mean, you should wait if you can to let their troponins come back to normal, to let their myocardial. I think you and I shared a patient that with a balloon pump over a weekend, their EF went from almost nothing to near normal.
Yes.
So you can see great recovery in patients that you wait on.
Yeah.
But I think, in terms of the stable ones, I mean, again, the literature better than I do that we're starting to see some literature to suggest that some of these stable patients with stable angina can be managed medically for long periods of time. I don't see those patients. So I don't know. Like I say, again, I only see I only see the numerator of them all. I don't see the denominator.
Okay. In terms of, so to summarize to the audience is, if you have a proximal LAD disease with 2 other vessels, it's no-brainer, diabetic or non-diabetic. We showed the data, old and new, that CABG is superior to PCI, regardless of what iteration of device you have, what iteration of stents you have, thin struts, Palmer-free, jacketed Palmer, whatever it is, seems CABG is to be the first option for these patients. For left main, depends on the syntax score. At a higher syntax score, the definitely better outcome with CABG. When the syntax score is low, then patient can go either way, but still require a heart team approach. But regardless, heart team approach should be discussed for these patients. Patients should be taken off the table, especially if they have stable blood pressure, they have no active chest pain, and discuss the options with the patient as well as a heart team approach. Is that a fair statement, Dr. Zair?
I think you summarized it very, very well. And I think that, as you know, we have worked very, very closely together for now a couple years. And it's been really, it's been kind of enlightening for me. This system that we're setting up here at the DMC is the closest that I've worked with cardiologists in my entire career in terms of discussing of patients, in terms of the heart team approach about these patients. And I think we have a pretty clear understanding of what each of our capabilities are. And I think that's an important message as well, that we're all on the same team here and we're all trying to get our patients. There's only 2 reasons we treat these patients. Number 1, more life. Number 2, better quality of life. And that's the important thing to keep in mind as we treat these complex patients. And it's not going to get any easier.
And you mentioned, Dr. Zair, a very important point where early before you started the talk is about, we are just treating the disease and the obstruction, but the disease state continues. So it's very important to fix a diabetes, fix a cholesterol, control the blood pressure and other risk factors, and quit the smoking. So these things, it's a process ongoing to prevent more progression of the disease so the patient doesn't come back for more revasc down the line.
Absolutely.
Well, we're close to the top of the hour. It's been a pleasure talking to you, Dr. Zair. A very informative presentation about multivessel coronary artery disease and left main disease and revascularization option. This, again, webinar series is going to come to you titled Heart to Heart Discussion. Our next webinar will be going to be the last Thursday of February, and it's going to be our guest faculty going to be Abir Berry, and she is our cardiologist at Huron Valley. Dr. Berry going to speak to us about heart disease in women, presentation, management, and prevention. Uh, Till that time, please be safe and watch this video and other videos on the DMC Medical Group YouTube channel. I am Shadi Reyes. Thank you for watching. I hope you have enjoyed this DMC Medical Group video. To find more content, webinars, and physician videos, visit dmcmedicalgroup.com.